Hello, I'm Jonathan Kay, reporting for Room Now from ACR Convergence 2021, which was supposed to have been in San Francisco, but I think we've all stayed home. I've got Kevin Winthrop here. Kevin is in Portland, Oregon, and I haven't seen Kevin in person for about 2 years, but here we are on Zoom. Kevin is the guru about infections and safety issues related to all of the drugs that we use. And today I'd like to talk to you, Kevin, about some abstracts that were presented, three posters on which you were an author. One was upadacitinib safety, another was baricitinib 9.3 years, final word on safety. And there was another one that was filgotinib safety, and then the oral surveillance study, the study about which everyone's been talking, had a poster about infection risk. And you know herpes, so I think let's focus right now on herpes. In the upadacitinib poster, the only thing that really stood out to me was the about 3.6 or 3.8 fold increased risk of herpes compared to adalimumab. And there was a similar increased risk of herpes with about the same hazard ratio in the oral surveillance study. What are your comments about that?
Yeah, sure. Well, just to remind you that it's not herpes, right? It's a herpes virus, but it's varicella. When we've looked actually at herpes simplex in some of these JAK studies and analyses before, we tend to see elevated risk with herpes simplex as well, but it's not as well reported or recorded or talked about. Nobody likes to talk about herpes, John. With reactivation varicella disease or herpes zoster shingles, I think all three of these posters, and then there's some real world data you mentioned, they all speak to the same thing. I mean, we're all seeing kind of the same rates of shingles reported long term. They're not getting higher or lower. They're staying fairly stable within these JAK inhibitor developmental programs. And when there's a comparator, particularly another DMARD or placebo, I mean, they're almost always 2 to 3-fold higher, and we are seeing that in all the studies you just mentioned, including the oral surveillance data. So it jives with what we've seen in the real world data. Population-based data where it's been looked at primarily with tofacitinib, because that's where most of the population data is with JAK inhibitors. But again, we see this 2-fold risk, and it seems to be fairly steady.
And there was a paper that was e-published back in July in Annals of Rheumatic Diseases that looked at about 14,000 patients from the rabbit registry. And they found a 3.6-fold increased risk of herpes zoster associated with targeted synthetic DMARDs compared to conventional synthetic DMARDs. So that's very similar to the increased risk of zoster that we're seeing in the individual study oral surveillance or in the upadacitinib data that you presented.
Yeah, it's very consistent. I mean, the one thing I'd say is that the Filgo abstract, which was also reported, I mean, the rates are a little bit lower in that compared to the other LTE experiences reported upon in the real world data. But again, the program was, these data were collected in different people in different places at different times. So it's hard to know how to compare. And there's no comparator in that LTE data. So, whether Filgo's relative risk is higher as compared to, a TNF comparator or not, we'll just have to see. But suffice it to say, I think there's a huge unmet need still, obviously, in shingles prevention, and I and you and others are working on that. But vaccination hopefully will be a key answer to that, and particularly as we're crawling out of this pandemic, we're on the backside. I like to say, we can focus again on preventing other viral infections like shingles.
So what are your recommendations for vaccinating patients? Should we make sure that patients are vaccinated with Shingrix, the recombinant zoster vaccine, before we start them on a JAK inhibitor?
Yeah, I mean, there is some data that suggests that flare is more likely to occur when Shingrix is used. The Calabrese's group at Cleveland Clinic reported a nice paper last year, published at ACR and then published, showing increased flare, particularly in people that had higher disease activity at baseline at the time of vaccination. I think certainly trying to vaccinate before JAK inhibition is ideal, given that's where the elevated risk really occurs. We should also mention prednisone. Obviously there's a dose-dependent risk there, and the lower you can get that dose, the better off someone is. We still don't know about the efficacy of that vaccine in these patients. Now, the label recently did change to accommodate vaccination in any immunosuppressed groups down to the age of 18. So it is, it is within the label. At some point, payers will probably start paying for it in people who are under age 50 who are immunosuppressed. But again, we still don't know the immunogenicity or ultimately the efficacy. It's probably diminished depending on what kind of DMARD a patient is taking, or perhaps what kind of underlying autoimmune disease they have. It wouldn't surprise me if we see, findings like we do with COVID vaccination, for example, and that some DMARDs really can mitigate the vaccine-induced response. So we have a lot to still figure out. But for now, I think, in daily clinical practice, I'd say, sure, I would try to vaccinate them before a JAK inhibitor.
So I write the prescription for the recombinant Zoster vaccine, give it to my patient. Do I tell them to withhold methotrexate for 2 weeks after their vaccine? And also,
that's a great question. We're hoping to address that in 2 studies that we're doing or trying to start anyway. One would look directly at that in the context of JAK inhibition, and whether altering a JAK or altering a methotrexate for a couple of weeks would make a difference. I guess my gut sense would be sure. I mean, I think if anyone's in remission or LDA, trying to hold their DMARD, and particularly certain types, a methotrexate, a JAK inhibitor, probably a abatacept, probably if you hold those things or skip a dose, you are going to assist the immune response. Whether it matters or not clinically, of course, we don't know. And, these are great questions for study. I think if I had a patient walk in the door on methotrexate and I was going to give it to him, I'd tell him, yeah, hold it for 2 weeks. But I'd also tell him that the data undermining or underneath that recommendation is quite thin and extrapolated from other experiences at this point.
So when I'm about to start someone on methotrexate, I get some baseline labs. I'll get hepatitis B and C serologies. I'll get a quantiferon TB gold test. Should I be vaccinating my patients with the recombinant herpes zoster vaccine when I start them on methotrexate to get them immunized so that when their therapies advance to a biologic agent or a targeted synthetic DMARD, they're already immunized?
I think vaccinating any vaccine, if you can do it before you start the DMARDs, is a good idea. And we always, say in the recommendations, try to vaccinate before you start immunosuppressing someone, just like you're trying to screen them for, hepatitis B and, Hep C and TB, et cetera. But you have to balance that, John, with disease activity, right? And if you've got someone who's got real hot autoimmune disease, that's not a great time to vaccinate them either. It may be better to vaccinate them once their disease is better under control, because we know, really active RA, for example, patients aren't going to respond to vaccination as well. So that's something you have to balance as you go, and I guess kind of make a call initially.
Well, that's really helpful. Well, we're keeping this to a relatively short time so that we don't take up too much of our viewers' time. It's always a pleasure and a privilege to get advice from Kevin Winthrop about these and other issues related to infection and drug safety. I'm Jonathan Kay, and for more on ACR Convergence 2021, go to rheumnow.com. Thanks.
Thanks, guys. Have a good one.